So colonic hematopoiesis is common. The primary perturbations that select for them are radiation and smoking. There are mutations, particularly in the p53 pathway, that are selected for with chemotherapy, particularly platinum agents. And individual mutations have unique effects on blood counts, including transfusion growth factor requirements. And there's much work to do here. So we're very excited that this is the beginning. And by next year, we'll have a 40,000 patient cohort at Sloan Kettering. And all of this is embedded in the consent patient sign for genomic analysis. So we're able to mine this data more and more. But then the other side of the coin, of course, is what happens when you get leukemia evolving from a clonal hematopoiesis state, and what can we learn about that? So in the past few years, we've been trying to understand what are the second and third hits that these early mutant clones get that give you disease. And the smoking gun has been mutations in signaling pathways. They commonly co-occur, including FLT3, RAS pathway mutations, as well as c-KIT mutations. And my lab has spent a lot of time trying to understand how do these mutations cooperate. And all of this work is published, but it makes an important point before I get to some newer work. And that was the fundamental observation that we were able to show that the combination of a TET or IDH mutation plus a FLT3 mutation induces methylation changes that either mutation does not induce alone, including, for example, the silencing of GATA2, which requires both mutations. So it's not caused by a single molecular event, but by a combination of molecular events. And the most exciting thing we did was we took our mouse model, where GATA2 is silenced by this combination of mutations. We put back in this single silenced downstream gene, and the leukemias differentiate and go away. And that suggests to us that if you can reprogram and reverse those combinatorial effects on gene regulation, you can actually differentiate leukemia cells into normal. And that's obviously the area that we want to go in and ask, can we use drugs or combination of drugs that can reverse these aberrant gene regulatory mechanisms, including hypomethylating agents combined with other agents, IDH mutant therapies alone and in combination with other therapies. And all of you know that the first example of a drug in the modern era, and we can't forget about retinoids as being the real poster child for this, are the IDH1 and IDH2 inhibitors. And this is just data from our lab where we did a lot of the preclinical work with Agios and Celgene showing that the IDH inhibitor on the left blocks serial replating of the malignant cell. And on the right, if you take a TET2 mutant cell, it doesn't matter. For those of you who do drug screens, I just want to point out one critical thing. If you look on the left, you can see that in the first two colony platings, the IDH inhibitor promotes the proliferation of those cells as they differentiate. So if you did a 5-day screen looking for drugs that actually abrogate the viability of leukemic cells, IDH would be the bottom of your list. It would actually score in the other direction. If you don't do extended 4 to 6 week culture, you can't read out the toxicity, even in a preclinical setting. We now know, of course, clinically, that these agents are very active, and we're all very happy that this drug was recently approved. And there's evidence of differentiation in vivo, including we've, in collaboration with our colleagues at Celgene and Agios and Oxford, taken neutrophils from patients who achieve remission and fished them out and shown that these cells have not only the IDH mutation, but all of the other mutations pre-therapy. So we believe fundamentally that as monotherapy, the IDH inhibitor induces a differentiation response that may or may not be maintained after you stop the therapy. And we've begun to ask, can you build on that success? We are very excited about the success of IDH inhibition, but we want to build on it. And so the first approach we took was to ask, could you combine a FLT3 inhibitor with an IDH inhibitor? And I won't take you through all the preclinical data, but needless to say, it works incredibly well. And we've now excited, Eitan Stan and I and others have thought about beginning a clinical trial combining a FLT3 inhibitor and an IDH inhibitor for patients that have both mutations. And so that's really where we've been. The question is, where are we going? So in the last few minutes, I just want to show you some really new data from the lab about another combination of mutations where we really didn't know where to go. Are there other cooperating disease alleles? So this work started from a few interesting observations from the IDH inhibitor trial. The first was a patient that we saw at Sloan Kettering that developed acquired resistance, and the only mutation that popped up in the resistant clone that wasn't there in the diagnostic clone was an NRAS mutation, suggesting to us maybe that NRAS IDH cells might not be sensitive to the IDH inhibitor. We then took all the patients on the phase 1/2 trial that we had access to material and did genomic analysis and asked, are there any mutations that predict for a lack of response to IDH inhibition? And the winner were NRAS mutations, KRAS mutations, and PTPN11 mutations. We only had one response amongst 22 of them. And this includes patients that either had a dominant clone with RAS mutations or even had a subclone. And that suggests some intriguing ideas. And we have preclinical data that RAS IDH cells or RAS TET cells don't respond to the IDH inhibitor or to a hypomethylating agent. So this has really encouraged us to actually ask, can we develop therapies against RAS mutant leukemia? I know that that's a question many have asked for many years, but we better start asking it because it's going to be a big problem, some of the new drugs coming. And so RAS mutations commonly occur with TET and IDH mutations, and so we thought it was worth exploring that. And we've made many models now of RAS mutant disease, and the most robust of them, that's the most developed, is a TET2 NRAS double mutant model that develops a progressive, transplantable, chronic myelomonocytic leukemia, which can evolve to AML. And we looked at that model and asked, what is unique about it? What's different about a TET2 NRAS cell versus an NRAS-only cell? And the thing that really leapt out at us was MAPK hyperactivation. So we saw greater activation of MAP kinase signaling in a RAS TET2 cell than in a RAS-only cell. And so that, we wanted to know two things. Why, and is it therapeutically relevant? So why? So we hypothesized that it might be due to methylation-induced silencing of negative feedback regulators of RAS output, including DUSPs and Sprouties. And what we found was a dense epigenetic silencing of a DUSP-Sprouty network, particularly Sprouty2, which is epigenetically silenced only in TET2 NRAS cells and not in TET2 or NRAS-only cells or in TET2 FLT3 cells. So we did the same add-back experiment we did with the GATA2. We put back in Sprouty2 and the leukemias go away. So these cells are absolutely dependent on keeping Sprouty down, and only in the cells that have both. If you do this in a RAS-only cell, they actually tolerate Sprouty2 add-back beautifully, or a TET2-only cell. We did this in vitro and in vivo. So then we went ahead and did in vivo studies, and we used MEK162 or bimimetinib from Array, and we've done selumetinib, we've done a number of other MEK inhibitors, and in every experiment we've done, the TET2 RAS cells are potently inhibited, and survival is prolonged with MEK inhibition. And we're very impressed, including on the bottom right, of the leukemic cell burden. And most importantly, we see a 100-fold reduction in the IC50 for TET2 NRAS cells versus NRAS-only cells. So that would predict that if you treated RAS patients, regardless of their co-mutational pattern, you might not see much of a response. But if you looked at the TET2 NRAS patients, they might be hypersensitive to MEK inhibition. And we've begun to test this preclinically with primary samples. And every TET2 NRAS patient we look at, their cells melt in vitro. And we've now done in vivo PDX modeling of primary samples in NSG mice. And they exquisitely melt when we give it to. We don't see that with RAS or TET2-only cells. So we believe that these co-mutations induce an addiction to MAPK signaling. So in conclusion, mutations in epigenetic regulators have a key role in the initiation and maintenance of hematologic malignancies. They can cooperate with other disease alleles to induce transformation by remodeling gene regulation. But epigenetic therapies have novel mechanisms of action, and we need to understand not only how to use them by themselves, but in combination with other therapies in rational ways. With that, I'll stop, and I just want to acknowledge that all the work you heard about on clonal hematopoiesis was done by Callie, Mike, Amit, and their team with Sean Devlin's biostatistical expertise, and Alan and Hiro did all of the TET2, IDH, and NRAS work, and are tremendous. Thank you much for your time, and I'm happy to answer questions if you have any.